neurogenic shock after IV fluids, what pressure should be used. Yeah, and so number one, I like what we're talking about. If you're going to have neurogenic shock, it's going to be cervical, right? Why is it going to be cervical when you have the damage? Because of the sympathetic ganglion. So when you sever the sympathetic ganglion, you're going to have what? No sympathetic tone. You're going to be hypotensive. You're going to have overwhelming what? Parasympathetic. You're going to be bradycardic. So, it's really not which pressor is going to be the one that you want, but I would have something that addresses the bradycardia as well as the hypotension. So sometimes, I tend to gravitate a little more towards norepinephrine, sometimes epinephrine, but it really depends, you know what I mean? So you want to address the bradycardia and the hypotension. Great answer. Colorectal holus viscous post repair, duration of IV antibiotics, 24 hours versus 40 days or 4 days. Well, the answer is, what bug did you grow? And how bad was the injury? So there's so many different things that we need to factor in there. Is the patient bacteremic or not? You know what I mean? So I don't want to say that there's a one set answer over here. It really depends on many things put together, but great question. Pseudomonal pneumonia, HAP-VAP, current duration is 7 days, antibiotics or 14. Once again, usually it's going to be 7 days. It depends on different antibiotics. You know what I mean? Some antibiotics got the approval for 10 days. Some got it for 14 days. For the board exams, 7-day course is going to be the answer. Procalcitonin implications, really going to be the answer for bacterial pneumonias. You know what I mean? It's going to be something that helps out when you think about VAPs, but it's so hard to distinguish a VAP, especially if someone comes in, it's immunocompromised, a transplant patient, high dose steroids, you worry about fungus, worry about PCP. Procalcitonin is not going to be as good. But on the board exams, if they give it to you, when are these procalcitonins going to be helpple? Not when they're positive, but definitely when they're negative. They would definitely have a very high negative predictive value. You know what I mean? Multi-vessel cabbage, dual antiplatelet therapy versus aspirinoli. Very spicy question. It really depends on risks and benefits, risk of bleeding. You know what I mean? But definitely that's going to be a very, very hot topic right now. Glutamine versus arginine in the ICU. Any role still in 2022? Unfortunately, not as much. You know what I mean? And definitely not on the board exams as of right now. Young man, isolated refractory hyperkalemia, intermittent HD. What do we do? Well, once again, what is the bigger picture here? You know what I mean? Can the young man tolerate HD? You're going to have big shifts in blood pressure, big shifts in fluids. If the patient's going to be very symptomatic from the hyperkalemia before doing these things or while doing these things, what are you going to do? Protect one thing, the heart. How are you going to do that? Insulin, glucose. What can you do? Maybe give some bicarb if they're going to be, acidemic, help out with the bicarb. So really it depends. Can the patient tolerate it? Do they have access? Are they hypotensive? But of course, you want to do things first to actually protect the heart. And of course, calcium gluconate, calcium chloride, protect the heart. And of course, giving the insulin and glucose, shoving that potassium where? Inside the cell. 12-year-old after lap appendectomy, died immediately post-op. It's just a statement. Either or, it just makes me sad. Anything that's 12-year-old, true story. I don't think we're going to know what the answer is over there. But I think that's all of them. Is there more? Oh my God. If the urine anion gap is negative from the gut, yeah. Yes, correct. Thank you, Michael, for the nice statement. Can you talk about how you might use the delta gap? Well, the delta gap really quickly, Don, is when we talk about a triple acid-base disorder, and when do we think about that? When you have a metabolic acidosis, and anytime you have any acid-base disorder, you always calculate the anion gap. If you have an anion gap, you need to calculate something called the delta gap. And I also will evaluate something, in my opinion, called a starting bicarb to see if there's going to be a triple acid-base disorder. And that's right. In the critical care boards, go figure. You could have a triple acid-base disorder. You could have individuals that could have both a gap and non-gap metabolic acidosis at the same time. And that's where I think about the delta gap. All right. I think we're pretty good.